Welcome everybody in this session. I am Dr. Nasrin Sultana Lovely, Associate Professor and Head of the Department of Physiology, Moinamoti Medical College, Kumilla. In previous class, we have finished up to diabetes mellitus. Today we'll study diabetes insipidus. Okay? Before starting that, here one question I would like to ask you one question here. What is the differences between pituitary diabetes, adrenal diabetes, and diabetes mellitus? Do you know this thing? What do you mean by pituitary diabetes? Who can tell me what do you mean by pituitary diabetes? What do you mean by adrenal diabetes? And already you have finished diabetes mellitus. So examiner might ask you like this question in Viva exam. What are the differences between pituitary diabetes, adrenal diabetes, and diabetes mellitus? Can you tell me what do you mean by pituitary diabetes? Who can tell me? Tanjimul. Tanjimul ke acho? Tanjimul আছে কিনা? What do you mean by pituitary diabetes? কেউ একজন বলো pituitary diabetes বলতে কি বুঝি আমরা? জানি কি? That is pituitary hormone. কোনটা? Basically growth hormone. If excess secretion of growth hormone occurs in our body, that time pituitary diabetes may occur. Why? Because growth hormone, as you know that diabetogenic hormone, growth hormone is one of the diabetogenic hormone. Growth hormone is one of the diabetogenic hormone. Excess secretion of growth hormone may cause pituitary diabetes. Why? Because growth hormone is one of the diabetogenic hormone. It increases blood sugar level, that is blood glucose level ta increase korbe. Kibhabe kore? It decrease uptake of glucose by the cell. Jodi growth hormone excess secretion body te hoy, beshi beshi ki hobe? তাহলে এক্সেস সিক্রেশন হলে ব্লাড সুগার লেভেলটা হাই হয়ে যাবে এবং এই এক্সেস ব্লাড গ্লুকোজ কি হবে কেন বেড়ে যাচ্ছে বিকজ ডিক্রিজ ইউটিলাইজেশন অফ গ্লুকোজ অর আপটেক অফ গ্লুকোজ বাই দ্য সেল আপটেকটা কমে যাবে গ্লুকোজের আপটেক কমিয়ে দিবে গ্রোথ হরমোন অলওয়েজ ডিক্রিজ আপটেক অফ গ্লুকোজ বাই দ্য সেল তাহলে গ্লুকোজ যদি সেলে ঢুকতে না পারে কোথায় থাকবে ব্লাডে তাহলে ব্লাড সুগার লেভেল উইল বি ইনক্রিজড এন্ড অলসো ইট ইনক্রিজ গ্লুকোনিওজেনেসিস তাহলে গ্রোথ হরমোন দুটো জিনিসের উপর কাজ করে একটা হচ্ছে ডিক্রিজ গ্লুকোজ আপটেক বাই দ্য সেল গ্লুকোজের আপটেক সেলে কমিয়ে দিবে আর একটা হচ্ছে ইট ইনক্রিজ গ্লুকোনিওজেনেসিস তাহলে বেশি বেশি নতুন নতুন গ্লুকোজ তৈরি হবে তাহলে এই দুটো প্রসেসের মাধ্যমে কি হবে ইনক্রিজ ব্লাড সুগার লেভেল বাই গ্রোথ হরমোন তাহলে গ্রোথ হরমোন দুটো কাজ করবে তাহলে এই যে এক্সেস ব্লাড সুগার লেভেল বেড়ে গেল এই এক্সেস ব্লাড গ্লুকোজ অলওয়েজ স্টিমুলেট বিটা সেলস অফ প্যানক্রিয়াস টু সিক্রেট more and more insulin তাহলে excess blood sugar মনে রাখবে বেশি বেশি blood sugar we have studied the regulation of insulin that is factors which stimulate insulin secretion we study here that excess glucose can stimulate more and more secretion of insulin তাহলে excess glucose level always secrete more and more insulin তাহলে কি হবে ultimately beta cells of pancreas will burn out তাহলে এই excess insulin secretion করতে করতে কি হবে beta cell গুলি burn out হয়ে যাবে and insulin resistance may develop that time and patient will develop type 2 diabetes mellitus due to insulin resistance তাহলে কি মেকানিজমটা বুঝতে পেরেছো how a pituitary diabetes happen in case of excess growth hormone secretion. Excess growth hormone secretion always decreases glucose uptake by the cell and also increase gluconeogenesis. So ultimate result is net effect is increased blood sugar level in the blood and this increased blood sugar level causes excess stimulation to beta cells of pancreas to secrete more and more insulin and ultimately if you give more work on the beta cells of pancreas it will burn out and ultimately no insulin secretion will be diminished insulin resistance may develop that time and ultimately diabetes mellitus occur in that patient so excess growth hormone secretion may cause pituitary diabetes okay now what do you mean by adrenal diabetes Adrenal diabetes, excess cortisol secretion. Of course, cortisol also one of the, as you know that cortisol is also one of the diabetogenic hormones. So cortisol also same thing. Cortisol also causes decreased glucose uptake by the cell and increased gluconeogenesis. It acts as that is counter hormone of insulin. Insulin just opposite actionটা করবে হচ্ছে cortisol and growth hormone. Insulin কি অ্যান্টি ডায়াবেটিক, তাই না? আর এরা হচ্ছে ডায়াবেটোজেনিক হরমোন। তাহলে cortisol কি করবে? Cortisol increases gluconeogenesis and decrease glucose uptake by the cell, so increase blood sugar level and development of the adrenal diabetes. তাহলে কি হবে? পেশেন্টের adrenal diabetes develop করবে। And what do you mean by diabetes mellitus? Already we discussed everything about diabetes mellitus. It may occur due to lack of insulin or insulin resistance. এখন ট্রিটমেন্ট যদি তুমি ইনসুলিন দিয়ে করো তাহলে গ্রোথ এই যে পিটুইটারি ডায়াবেটিস কি হবে? উইকলি ইনসুলিন সেনসিটিভ। মনে রাখবে পিটুইটারি ডায়াবেটিস is always weakly sensitive to insulin. Adrenal diabetes is moderately sensitive to insulin, and diabetes mellitus is strongly sensitive to insulin. This is the basic differences between pituitary diabetes, adrenal diabetes, and diabetes mellitus. First, you have to tell the definition, then cause. Pituitary diabetes and adrenal diabetes, same cause: decreased glucose uptake by the cell and increased gluconeogenesis. And in case of diabetes mellitus, cause ki no utilization of glucose by the cell because a lack of insulin, no utilization of glucose by the cell. Glucose entry hote parbe na ebong kono utilization hote parbe na. Ar insulin treatment jodi dei tale amra ki bolbo? Weakly pituitary diabetes weakly sensitive to insulin, adrenal diabetes is moderately sensitive to insulin, and strongly sensitive hoche diabetes mellitus, strongly insulin sensitive. These are the basic differences between pituitary diabetes, adrenal diabetes, and diabetes mellitus. Already 47 students added with me. Now, one thing we left here. What do you mean by insulinoma? What do you mean by insulinoma? Any oma means tumor. Oma means tumor. See here, insulinoma or hyperinsulinism. That is, if excess insulin secretion occur, it is also harmful to our body. See here, causes of insulinoma or hyperinsulinism: adenoma of islets of Langerhans. That is, if there any tumor occurs in the islets of Langerhans, this may cause insulinoma or hyperinsulinism. Features: if insulin secretion occurs more, there some features may happen in your body that time. That is, neuropsychiatric symptoms, nervousness, confusion, stupor means lethargic type condition, and hypoglycemic attack. Of course, if more and more insulin secretion occur, so more and more glucose uptake by the cell and no glucose in the blood, so of course hypoglycemic coma may occur that time. Hyperinsulinism, that is, if there is a insulin lack, that time diabetes mellitus occur. If there is more insulin secretion occur, that time hyperinsulinism occur. That is, more insulin causes hypoglycemic attack and cause adenoma of the islets of Langerhans, and features neuropsychiatric symptoms, nervousness, confusion, stupor, and main thing, hypoglycemia. If excess insulin secretion occur, hypoglycemic attack or hypoglycemic coma may happen that time. This is about insulinoma or hyperinsulinism. Today we'll study diabetes insipidus. This is very important topics for a written exam and also for viva exam. What is diabetes insipidus? And it may come like this way, short note about diabetes insipidus. Okay, it is the syndrome. See here, what is the definition of diabetes insipidus? It is the syndrome that results from deficiency of ADH or failure of the kidney to respond to ADH, results in the formation of a large volume of dilute urine, ranges 5 to 20 liter or more per day. So diabetes insipidus, it is the syndrome that results from deficiency of ADH, that is antidiuretic hormone, which is secreted from posterior pituitary gland. As you know that ADH, from where ADH secretion occur? Of course, obviously from posterior pituitary gland. Another name of ADH is vasopressin. Why it is called vasopressin? Because it causes contraction of the vessels. That's why, or constriction of vessel. That's why another name of ADH is vasopressin. Okay, it is the syndrome that results from deficiency of ADH, either deficiency of ADH or failure of kidney to respond to ADH. ADH secretion, okay, but kidney cannot respond to ADH. That time diabetes insipidus may occur. Okay. And ultimate result, formation of large volume of dilute urine. You know that ADH, what is the function of ADH? ADH, antidiuretic hormone, that is it causes antidiuresis. Diuresis মানে কি? বেশি বেশি micturition হওয়া, urination, ঠিক আছে? Diuresis মানে কি? More than 3 liter of urine যদি আমরা excrete, more than 3 liter of urine per day, this is called diuresis. Normal urine volume আমরা জানি যে 1.5 to 2 liter per day, তাই না? যদি more than 3 liter হয়, if you excrete more than 3 liter per day, this is called diuresis. তাহলে এই diuresisটাকে prevent করে কে? ADH, that is antidiuretic hormone. ADH, antidiuretic hormone. If there is problem or deficiency or congenital deficiency of ADH secretion from the posterior pituitary gland, that time large volume of urine, dilute urine, passes through passes large volume of dilute urine. Person may pass large volume of dilute urine if there is congenital deficiency of antidiuretic hormone, or there is any problem in the renal tubule, that is distal convoluted tubule, collecting duct. In this region, if there is any problem, that time ADH will not respond to that area, result in the formation of large volume of dilute urine. And what is the amount of urine in case of diabetes insipidus? This is very popular viva question, very important questions for you. Always remember that 5 to 20 liter or more, that is more than 20 liter. In diabetes insipidus, patient may excrete more than 20 liter of urine per day they can excrete, but range 5 to 20 liter according to latest edition, 23rd edition Davidson international book, medicine book Davidson. I have taken this range from international medicine book Davidson, 23rd edition, 5 to 20 liter or more. That is, it may be more than 20 liter per day. Diabetes insipidus patient, that is large volume of urine they excrete due to deficiency of ADH or failure of the kidney to respond to ADH. Symptoms, what will be the symptoms of diabetes insipidus? Polyuria and polydipsia. Because they excrete, as they excrete large volume of dilute urine, patient may suffering from polydipsia. তাদের কি লাগবে? ঘন ঘন পানির তৃষ্ণা লাগবে, এবং পলিইউরিয়া কি? বারবার ওয়াশরুমে যাবে। এবং পলিডিপসিয়া মানে কি? পলিইউরিয়া হচ্ছে এক্সেস ইউরিন ফরমেশন, এক্সেস ইউরিন এক্সক্রিশন, এন্ড পলিডিপসিয়া হচ্ছে এক্সেসিভ থার্স্ট। ঠিক আছে? if person যদি বেশি বেশি পানি না খায়, তাহলে কি হবে? he or she will suffer great problem. তাহলে পারসন কে কি করতে হবে? ডায়াবেটিস ইনসিপিডাস patient always take more water, because as they lost more water through urine, that's why they have to take more water. Okay, two symptoms highlighted, point here: polyuria and polydipsia, and patient has to take more and more water. Okay, now types of diabetes insipidus, types and causes: central diabetes insipidus and nephrogenic diabetes insipidus. Okay, see here, central diabetes. What do you mean by central diabetes insipidus? it is caused by failure to produce or release ADH from the posterior pituitary due to head injury or infection or congenital. Already I have said that if there is congenital deficiency of ADH or head injury or any infection which causes destruction of the posterior pituitary gland and failure to produce or release ADH from the posterior pituitary gland causes central diabetes insipidus. That is cause in the central cause. Central cause মানে হচ্ছে problem in the posterior pituitary gland due to head injury, infections or congenital deficiency of ADH. Now number 2, nephrogenic diabetes insipidus. What do you mean by nephrogenic diabetes insipidus? Nephrogenic diabetes insipidus caused either failure of the counter current mechanism to form a hyperosmotic renal medullary interstitium or failure of the distal tubule, and collecting ducts to respond to ADH. So nephrogenic diabetes insipidus happen due to two reasons. It may happen due to two reasons. Either failure of the counter current mechanism. As you know that counter current mechanism makes the urine hypertonic or hyperosmotic because normal urine is always hypertonic. That is osmolarity is 600 to 900 or 600 to 800 milliosmoles per liter. So if the osmolarity greater than plasma osmolarity, this is called hyperosmotic or hypertonic. So normal urine osmolarity is 600 to 800 milliosmoles per liter. So obviously it is hypertonic. So normally an individual, healthy individual always excrete hyperosmotic or hypertonic urine. This is very, very important viva question. Normal, always examiner might ask you like this, normal urine is hypotonic, hypertonic or isotonic. Of course, your answer should be here. Normal urine is always hypertonic because osmolality more than plasma. Normal plasma osmolality is 300 milliosmoles per liter, but in case of urine osmolarity, as urine osmolarity is 600 to 800 milliosmoles per liter, that is, it is greater than plasma osmolality. Of course, this is hypertonic. So normal urine is hypertonic or hyperosmotic. So if there is any problem in the counter current mechanism, so it cannot form hyperosmotic renal medullary interstitium. That time urine will not become hypertonic. So more and more dilute urine production occurs. So nephrogenic diabetes insipidus, one of the major cause failure of the counter current mechanism, which is very much essential to creation or formation of hyperosmotic renal medullary interstitium. Now, another reason, failure of the distal tubule, and collecting duct to respond to ADH. As we know that in presence of ADH hormone, this area is more permeable to water. Without ADH, this area is impermeable to water. Okay, so in presence of ADH, in distal tubule, and collecting duct is permeable to water, and water reabsorption occur, and urine become that time hypertonic or hyperosmotic urine formation occurs. But if there is failure of distal tubule, and collecting duct, failure to respond to ADH, there is no ADH present, so distal tubule, and collecting duct is more and more impermeable to water. No water reabsorption takes place in this area, so dilute urine production occurs that time. These are the reasons of creation of central diabetes insipidus and nephrogenic diabetes insipidus. You have to know these things very nicely. Now, what are the differences between diabetes mellitus and diabetes insipidus? For written exam and also for viva exam, this question is very important for your written and viva exam. What are the differences between diabetes mellitus and diabetes insipidus? Cause. Already you knew that cause, that diabetes mellitus either insulin deficiency or insulin resistance. Diabetes insipidus, ADH deficiency or ADH resistance, of course, because if the ADH resistance means if kidney is non-responsive to ADH, that is when renal tubule, that is distal tubule, collecting duct not respond to ADH, this is means ADH resistance. Okay, cause insulin deficiency or insulin resistance. Here diabetes insipidus cause ADH deficiency or ADH resistance. Types. In case of diabetes mellitus, type 1 diabetes and type 2 diabetes. In case of diabetes insipidus, central and nephrogenic diabetes. Hyperglycemia. In diabetes mellitus, hyperglycemia present because there is no insulin. So increased blood sugar level here. And in case of diabetes insipidus, hyperglycemia absent. There is no relation with hyperglycemia. Now, glycosuria. Glycosuria, that is passing of electrolytes, passing of glucose in the urine. Passing of glucose in urine is called glycosuria. In diabetes mellitus, of course, glucose level high blood sugar level and glucose, passing of urine with glucose. Glycosuria occur always in diabetes mellitus, but here there is no relation with glycosuria in diabetes insipidus. Urinary osmolarity hypertonic because more and more electrolytes passes, osmotic diuresis occurs in diabetes mellitus, so urinary osmolarity increased in diabetes mellitus, so hypertonic. But in case of diabetes insipidus, watery urine, that is no electrolyte passes through the urine, so urine osmolarity hypotonic. Dilute urine is always hypotonic. Hypotonic means here osmolarity may become 50 milliosmoles per liter in large when patient excrete large volume of urine. That time urine osmolarity decreases, goes downwards, and osmolarity become 50 milliosmoles per liter. But normal hypertonic, here urine osmolarity may reaches 1200 to 1400 milliosmoles per liter, but normal urine osmolarity is 600 to 800 milliosmoles per liter. Urine specific gravity high, here low. Treatment. Diabetes mellitus patient treated by insulin oral hypoglycemic agents, and diabetes insipidus patient treatment intake of plenty of water. As I said, that they have to take plenty of water, more water, because they always lose more and more excessive water excrete through the urine, so they have to take plenty of water. And treatment of underlying cause, যে প্রবলেমগুলি হবে সেই কজের অনুযায়ী আমাদেরকে ট্রিটমেন্ট দিতে হবে. This is the differences between diabetes mellitus and diabetes insipidus. Now, I want to start glucagon. Glucagon today. Glucagon, like insulin, glucagon is a large polypeptide. It has a molecular weight of 3,485, composed of a chain of 29 amino acids. Glucagon, of course, anti-action of insulin, counter-regulatory hormone of insulin. Anti-diabetic hormone is only one hormone, that is insulin, but diabetogenic hormone, lot of hormone is diabetogenic hormone, and one of them is glucagon. What are the name of diabetogenic hormone? First one, glucagon. Second, glucocorticoid, that is cortisol. Then thyroid hormone, growth hormone, catecholamine. আর কি বলো তো?
Epinephrine, norepinephrine.
Yes, catecholamines. These are all under catecholamines, means epinephrine, norepinephrine, growth hormone, thyroid hormone. Then আর কি কি বলতে পারি আমরা? গ্লুকাগন আর কর্টিসল. ওকে, গ্লুকাগন দ্যাট ইজ কি অ্যান্টি ইনসুলিন অ্যাকশন। ইনসুলিন যে কাজগুলি করবে যার তার অপোজিট রেসিপ্রোকাল ফাংশনটা করবে হচ্ছে গ্লুকাগন। বাট লাইক ইনসুলিন ইট ইজ পলিপেপটাইড হরমোন। ইনসুলিনও একটা প্রোটিন হরমোন, গ্লুকাগনও হচ্ছে কি প্রোটিন হরমোন, এবং মলিকুলার ওয়েট কত 3,485, কম্পোজড অফ এ চেইন 29 অ্যামিনো অ্যাসিড। ঠিক আছে, আর সোর্স কি বলবো আমরা? দিস ইজ ভেরি ইম্পর্টেন্ট MCQ. MCQ question. Source of glucagon: A or alpha cells of islets of Langerhans, also upper GIT. As you study in digestive physiology, that is in gastrointestinal physiology, that glucagon one of the local hormone of GIT. Glucagon is one of the local hormone of GIT. Already you have studied this thing. So it is known to you that glucagon is one of the local hormones. So it also secreted from upper GIT, gastrointestinal tract. And mechanism of action: glucagon always acts by second messenger system, that is by cyclic AMP second messenger system. This is very important MCQ question. How glucagon, mechanism of action of glucagon, or how glucagon acts by second messenger, cyclic AMP second messenger system. Okay. See here, glucagon antagonizes the action of insulin, so it is called hyperglycemic hormone. Of course, it is always act just opposite action of insulin. Insulin is called hypoglycemic hormone, so glucagon antagonizes the action of insulin, so it is called hyperglycemic hormone. Glucagon is synthesized as much large pro-glucagon precursor, just like insulin. As we study in insulin synthesis, that insulin is synthesized from pre-pro-insulin, then pro-insulin, then final product is insulin. Just glucagon like that. Pre-pro-glucagon, pro-glucagon, then glucagon. Protein hormone গুলি কোথা থেকে সিক্রেট হয়? Of course, rough endoplasmic reticulum. Glucagon circulates in the plasma in the free form. ঠিক আছে, এটা কিন্তু বাউন্ড করে না। তাহলে glucagon circulates in the plasma in the free form. Plasma half life is only 5 to 10 minutes. আর ইনসুলিন কত বলেছিলাম? ইনসুলিন বলেছিলাম 5 minutes according to Gannon, আর 3 to 5 minutes according to Gannon, আর 6 minutes বলেছিলাম according to Guyton. আর but in case of glucagon, see here, plasma half life 5 to 10 minutes. And metabolism কোথায় হচ্ছে? Of course, obviously liver. Main metabolic organটা কি আমাদের বডিতে? liver. Glucagon is quickly metabolized in the liver. Now, liver is the, always remember one point here, liver is the primary target organ of glucagon action. That is prime organ. যেখানে first কাজ করবে glucagon, সেটা হচ্ছে কি? liver. মনে রাখবে, in the portal vessel এ দেখা যায় glucagon secreted in the portal vein first, এবং action started within the liver first, then periphery. তাহলে পেরিফেরিতে পৌঁছানোর আগেই সে কোথায় আগে কাজ করবে? গ্লুকাগনটা লিভারে কাজ করবে, এবং লিভার ইজ দ্য প্রাইমারি টার্গেট অর্গান ফর গ্লুকাগন অ্যাকশন। এবং মেজর অ্যাকশন গুলি কি কি? দ্য মেজর অ্যাকশনস অফ গ্লুকাগন, লাইক ইনসুলিন, নট লাইক ইনসুলিন, অ্যান্টি ইনসুলিন অ্যাকশন। See here, glycogenolytic, whereas insulin is, ইনসুলিন কি করে? গ্লাইকো স্টিমুলেট করে কি? গ্লাইকোজেনেসিস। As we know that insulin stimulate increase glycogenesis, but see here, glucagon glycogenolytic, that is lysis of glycogen. Glycogen কে ভেঙে ভেঙে কি করবে? গ্লুকোজ করে ফেলবে। গ্লুকাগন কি করবে? ব্লাড সুগার লেভেল হাই করে, ডায়াবেটোজেনিক হরমোন। তাহলে it always কি করে? conversion of glycogen to glucose. So it is glycogenolytic. Number 2, lipolytic, but insulin anti-lipolytic. Anti-lipolytic. We know that insulin is anabolic hormone. First thing, insulin is anabolic hormone. We to you that insulin is anabolic hormone, anti-catabolic hormone, anti-diabetic hormone, anti-lipolytic hormone, anti-ketogenic hormone. These 5 functions, it is known to you, but see here, opposite action of glucagon: glycogenolytic, lipolytic, that is its breakdown of lipid, ketogenic, ketogenesis, it causes ketogenesis, whereas insulin anti-ketogenic function, but gluconeogenic, whereas insulin always decrease gluconeogenesis, but it stimulates gluconeogenesis. And calorigenic action, there is one adding point here, is glucagon is calorigenic action. Glucagon has calorigenic action. Okay, these are the major functions of glucagon, but for written exam, for viva, this slide for viva exam, what are the major functions of glucagon? If examiner asks you like this, what are the major functions of glucagon, you can tell like this: glycogenolytic, lipolytic, ketogenic, gluconeogenic action, and calorigenic action. But for written exam, you have to write on carbohydrate metabolism, on protein metabolism, on fat metabolism. You have to write down like this way. In next class, we'll discuss about details about glucagon, and somatostatin. Okay, that's all for today from me. Thank you, everybody. Thank you very much.